Why heart health? Because the February is American Heart Health month and month awareness, and we want to just talk about it and make ourselves aware of the problems of the heart and how we can overcome those problems. Some small facts about the heart. As all of us know, heart beats around 75 times a minute. If you add them up, in a day, it beats around 100,000 times, and in a year, about 40 million times. And in a person who is 75 years old, is around 3 billion times our heart has beaten. Now, when we talk about billion, it doesn't seem, I mean, we are used to saying billion every time, but we don't know how big the billion is. There are some facts. For example, from the time of birth of Jesus is around 1 billion minutes, not more. That's how a billion is a big number. What else? With each beat, our heart pumps around 80 ml of our blood throughout the body. Now, if we add them up, in a year would be around 876,000 gallons of blood. And the same person who lives 75 years to grow 75 years old is around 65 million gallons of blood. It's going to be pumped throughout our body. So we need to take care of our hearts, right? Heart disease is a leading cause of the death in the United States, and is estimated around 600,000 deaths every year due to heart disease. Coronary heart disease is the most common cause of the heart, the death, basically, and kills about 400,000 people a year. How much does it cost us? Is around $108 billion a year. That's for the healthcare services, for the medications, and the loss of the productivity. This is a really big number. CDC is the Center of the Disease Control, believes we can basically prevent 1/3 of this death, which is around 200,000 people a year, which is a big number if you be able to do that. And CDC believes that key risk factor for the heart disease are high blood pressure, high cholesterol, and also smoking. And they estimate that about half of the Americans have at least one of these risk factors. And they approach it with basically with the ABCs of the heart health and say, hey, you better take an aspirin a day, take a control of your blood pressure, do the management of your cholesterol, and also you better stop smoking if you want to prevent those. You want to be one of those 200,000 people who want to prevent the death. We want to have a different approach here. We want to talk about a little bit, basically elaborate this, and talk about the risk factors, the modifiables and non-modifiables. There are some risk factors like age, for example. We cannot do anything about it. I mean, it's not modifiable. There are some that are modifiable. The non-modifiables are age, sex, the race and ethnicity we are in, and also location. Location has a question mark in front of it because you can change your, I mean, basically, I think the CDC says the location because of the habit that people learn when they grow up in an area. Now, if you move to some other area and lose those habits, most likely you will lose that risk factor also. Age. Most of the disease, like cancer, like heart disease, these are the older people, most of the time, older people problem. The older you get, the most likely you will develop the heart disease. Right? For example, it's normal for an 80-year-old person to get a heart attack, but not for a younger person. Then age is one of those non-modifiable risk factors. We cannot do anything about it. We cannot stop the time, unfortunately. What about sex? Basically, the men they are more prone to have heart attack compared to female. And across from all the ethnicities, you can see the men are basically, being a male, puts you more in danger to have a heart problem. Ethnicities, basically blacks are the higher risk. Being a black person is a higher risk factor compared to being an Asian. And basically a black man is at the highest risk for a heart problem. What about location? This is a map from the CDC. It says in the southern counties, as you see, there are more heart attack and heart problems reported, as you see. But for example, Louisiana and Mississippi and part of the Texas, which is close to Louisiana, maybe because of the Cajun food. You never know. But since we grow up in a region and we grow up with the habits and we follow those habits for the rest of our lives, maybe that's a risk factor. Now, if that person who is in Louisiana or Mississippi, if moves to Washington, if doesn't follow those habits anymore, most likely will lose that risk factor. Modifiable risk factor, like high blood pressure, high cholesterol, diabetes, smoking, unhealthy diet, inactivity, obesity, stress, and other things. Also excessive alcohol use. These are really important risk factors for developing heart problem. Now, we start with high blood pressure. The goal is to bring the blood pressure 140/90, below that, basically. Now, how we can do that? We can do it with medication or lifestyle modification, like any other disease that we have. Diabetes, high cholesterol, everything we do, lifestyle modification, medication. Always lifestyle modification comes first. We need to do that before we start any kind of medical intervention. And also throughout the years that we also, if we take the medication, we need to basically stick with those lifestyle that we changed. Now the good thing is, if somebody has diabetes, high blood pressure, cholesterol problem, if you do modify your lifestyle, that is good for all of the problems that you have. They recommend, for example, for part of the lifestyle modification, to lose some weight. If you lose around 10 pounds, that helps up to 20 millimeters of mercury to improve your blood pressure. That's a big deal. Also, a smoking cessation, DASH diet, which is a dietary approach to stop hypertension. That's like a low sodium diet and a high potassium and calcium diet, which helps with the blood pressure. Moderation use of alcohol instead of excessive use of alcohol. Increase physical activity. Now, for all of these, there have been some studies, and they come with a table. As you see here in the weight reduction part, somebody who loses the weight is around 5 to 10 pounds. For each 10 kilograms that you lose is 5 to 20 millimeters of mercury, the blood pressure improves. Now, if you do follow the DASH diet, another 8 to 14 millimeters of mercury. For if you lower your sodium consumption, another 2 to 8. Physical activity, 4 to 9. Instead of drinking too much alcohol, you make it moderate, another 2 to 4 millimeters of mercury. I'm putting some Persian in it. Now, let's say somebody has a blood pressure of 160, which definitely needs to take blood pressure medication, right? If follows these lifestyle modifications and loses some weight, do some physical activity, maybe doesn't need to take medication anymore, right? Because 160, we bring it down to 140, and we can do it with weight loss and physical activity. The good thing is, for example, physical activity, if you stick with it, you can lower your blood pressure up to 9 millimeters of mercury. Now, that regardless of if you're losing weight. If you lose weight also, then basically twice as much. What about diabetes? Definitely we should not ignore our diabetes, because that's a really big risk factor for heart problem. What is the goal? The goal is to stop the progression of diabetes, complications, right? Because we cannot cure the diabetes, unfortunately, as of now. How we can stop the progression of diabetes with tightly controlled, basically monitor our blood sugar and also tightly control it. And the goal is to keep the sugar, the fasting sugar, below between 70 to 130, and non-fasting sugar below 180. And also, if we check the hemoglobin A1C, below 7%. Now, what is hemoglobin A1C? Is basically part of the red blood cells that are attached to the sugar in our blood system. And when we check this, it shows how good or bad the sugar has been controlled for the previous 3 months. Now, this is a good way to help us, to help the patients, basically. How? Because some people may cheat. I mean, they know that, I mean, they don't know they're cheating to themselves. They may don't eat anything for a day or so and come and we check their sugar. Hey, your sugar is 100, good job, go home, continue your medication. But now we have this tool to check their hemoglobin A1C. Let's say is 10. We tell them, hey, your sugar is 100, but how come your A1C is 10? That means other times he hasn't been basically controlling his or her sugar. Then basically is monitoring the diabetes, patient education, a good diet, exercise, and the end comes the medication to help even more to control the diabetes. What about the high cholesterol? I mean, do we, all of us know our numbers? Do we know which numbers are good? We need to educate ourselves. The goal now is to keep the bad cholesterol. The LDL is a bad cholesterol, is a low density lipoprotein, below 70. Actually, it used to be 100 up to 2 months ago. In December, American Heart Association, they issued their new guidelines. Their recommendation from 100 pressed down to 70. They used to say, okay, if it's somebody who doesn't have a problem with their heart and or at the risk for diabetes, or they have diabetes, we better keep the cholesterol, bad cholesterol, below around 100. Rarely, when a patient had diabetes and also documented heart attack or stroke, it was recommended, hey, you can take it down to 70. That's not a big deal, but you can do it. But now they really press it to bring it down to 70. And that's because a newer study has shown the statin, which is the mainstay of controlling the cholesterol, using the statin shows the lower events, cardiac events for the patients. All of us know about healthy and unhealthy diet. It's just a matter of temptation that make us to eat more or eat unhealthy. Then basically we need to make smarter choices. When we are dealing with food, we need to take smaller portions, for example, or do the moderation. And whatever we do to help us to lose weight or have a healthy diet, we need to stick with it and do it consistently. Obesity is another big risk factor for the heart problem. Again, we need to have smarter choices, smaller portions, moderation, and consistency. This is, I took from CDC. As you see, for example, 1994 up to 2009, you see how obese the America gets. We didn't have that many. For example, we didn't have any people here in 1994 who had the BMI, I mean the 26%, to have 26, we had obese, but we didn't have that population to be over 26% in here. But as time passes by, you see we have even red and more red in recent years. Now, along with that, the diabetes happens. You see, the more obese we get, the more diabetes. That goes for high blood pressure also and high cholesterol. Exercise versus inactivity. I mean, that's again comes to your choices that you make in your life. Everybody knows exercise is good. Everybody knows not being active is bad, but it's just a matter of choices that we make. And this guy is really lazy. Now, we all are smart, but we may not make a smart choice. This guy is really smart. In New York, after they banned the big jar of sodas. This guy now buys 2. It's a smart thing to do, but it's not a smart choice to have. We need to have motivation for everything we do. I mean, for losing weight also, we need motivation. We need to find what is our motivation to stick with it and lose weight. Now, somebody may want to look like that or this, because nobody really likes to be like that or that. Sometimes we are scared, and we may start exercise for any reason. Unfortunately, there is no dinosaur anymore. How much the exercise is recommended? At least 150 minutes per week. That makes it like 30 minutes a day for 5 days a week of moderate intensity. What does it mean? That means to bring up your heart rate around 50 to 70% of your maximum heart rate. And how do we calculate our maximum heart rate? Is 220 minus the age. If somebody is 60 years old, the maximum heart rate would be around 160. Now, if we bring it to 80 to 100, we can accomplish that with just walking in the neighborhood. Now, if somebody doesn't have any contraindication, we can do resistance training 3 times a week, which even helps more. And we need to tell our patients, tell our families, if somebody really wanted to start a heavy physical activity, they need to talk to their provider before doing so to make sure they're okay. Smoking, everybody knows. I mean, smoking is bad. Everybody knows we need to stop it. But again, the temptation is there to keep smoking. That again goes to the smarter choices that we make. Now, this is the March 12th is the no smoking day in England. Now, every day, some day in March, every March they have this day. I Googled it today in United States. I couldn't find any day. But they have this day, some day in March, and basically that's a no smoking day. I mean, that's how you get people's awareness to do something good. But there are good news. This is the map of United States, how much we used to smoke in 1998. The darker blue shows the more smoking. In 2003, there are less darker blues. And now in 2008, we have even less darker blue. That shows the people awareness of the smoking is not good. Okay? And that goes for everything. For example, everything helps, what I mean. Like there is no more advertisement for smoking on the streets or on the TVs. I mean, the actor or actors that are famous are not smoking anymore. That helps to kind of cut back on smoking. What about the supplements? Do they really help? Can they help to prevent any cardiovascular disease? We're not sure. And this is United States Preventive Services Task Force. Their position actually issued today, 25th of February, which is today. The email and the internet is fabulous because when you are in their listserv, I mean, they email you whatever news is there. And I got this email today, and I went and checked it out in their website. That's their recommendation. Regarding using multivitamin to prevent, that's the keyword, to prevention of cardiovascular disease or cancer, this data is not enough, is insufficient to take multivitamin in the purpose of preventing heart disease. What about the other nutrients? Again, is insufficient data, except for beta-carotene and vitamin E, because we know vitamin E and beta-carotene are not recommended for the purpose of preventing cardiovascular disease and cancer. And they are against it, to use it for this purpose. Now again, USPS task force, they are kind of moderate, and any organization that have their own recommendations, but this is one of the big organizations that most of the time we family physicians follow. I think this is my last slide. Any question?
Awesome.
Yes, sir. Now, any question from strangers.
Well,
Go ahead.
well, I am stranger than most.
Let me have the microphone.
Sure.
So, but how about people that have like high blood pressure? Should
Mhm.
they monitor their heart rate when exercising? Like, if say if they have like stage 2 hypertension, should there be a risk of their
Of course, because you don't know what kind of underlying problems you already have. Now, if somebody comes, for example, tells me, hey, doc, I want to start running, I tell him, no, don't start running all of a sudden if you haven't been running for a long time. And if that person says, no, doc, I want to run no matter what, I will recommend that person to take a stress test first to make sure her heart or his heart can take that stress. Because inactivity for a while makes every part of our body lazy, including our heart. Now you want to put it under stress. Now you want to make sure in an environment it is controlled, which is you can do the stress test to make sure that heart can take that stress. That's my recommendation to do so.
Okay, thank you. Does anybody else have any questions?
Yes, ma'am.
On that chart, why was it that the highest risk were in black males? Repeat the question.
The question is, I'm repeating because the question when is said is not picking up by the camera. Why is the higher chart the bar goes for the black male?
Right.
Because being a male is a risk factor compared to being a female is a risk factor for heart problem. Also, across from ethnicities, the blacks have higher rate of having a stroke or heart problem. Now, compared to next one was Native Americans. The next were whites, then Hispanics, then Asians. Now, that's because of ethnicity. The reason, I really don't know what the reason is. Nobody might not know what the reason is, but that's how the races are. I mean,
I have a comment here. So, what is that one? In all races, African Americans are high risk for almost most
everything,
of the
yeah.
major diseases. Cancer, heart disease, chronic diseases. And it comes with the ethnicity, the genetics, obviously makes a big impact. The second one is the social economic status. So if someone doesn't have the social economic status, like I said, it's not a problem to be an African American, but a lot of those people don't have insurances. If you have like 8 kids that need to take care of, so you don't seek medical attention. And when they get sick, it's already late. So there's no a space for prevention in there. It's not like white people don't have that problem. White people have the problem too, but when you compare, the percentage of those people are more blacks than whites. And that goes across cancer, heart disease, diabetes, inactivities. So it's kind of like an epidemiology explanation.
But regardless of that, the genetic is the most thing, because when you, like she said, if you bring up the basically the socioeconomic rate, that goes even, for example, a white person who is educated, and let's say if with education comes being rich, if educated and rich compared to a white person who is not educated and rich, this person who is not educated and rich is less educated and less rich, because the choices they make is more risky than the person who is educated already, right? And that's one part. Or also genetic plays a role. Yes, sir.
Okay, so were those statistics just from the U.S. or from international?
These are mostly from U.S. and all of the statistics are from the CDC.
I see. So how do our statistics compare to other countries, so to speak? Is the risk for a, let's say, Caucasian male here in the U.S. greater than that of a European Caucasian male, or is it
When they say United States, normally, I mean, that's definitely, this is statistics for United States, but that is comparable with the other advanced countries, like, for example, Western Europe, right? But when it goes to Eastern Europe, that they have their own statistics, that's different, because the lifestyle changes, okay? When it goes to, for example, Africa, different lifestyle. When it goes to Asia, different lifestyle.
But the proportion remains the same.
Yes, of course. For example, you don't find that many heart problem, basically, in a country like Asia, but they have some other problems in Asian countries. But the proportion remains the same. No more questions? Yes, ma'am.
I have a question. You talked about the level of LDL. I want to know about the different amounts of LDL for screening the disease. For example, if a patient have ischemic heart disease, is different with another patient or not? If we want screening the people, we treat the high LDL.
I didn't get exactly the question.
If someone has heart disease, they have to have a lower LDL versus a normal person.
Yeah, definitely. When I was talking about the 100, up to 2 months ago, which was 3 months ago, which was December 2013, the guidelines were for somebody who's healthy and no problem at all and no risk factors, the LDL goal was to be below 190. Somebody comes in, has no problem, no risk factor. The LDL, if it was 185, that would be okay. Even with 90, let's say it was the LDL, not the not the cholesterol, not the total cholesterol, just the LDL. If it was 195, then we would modify it with, for example, lifestyle modification and those kind of stuff. If it didn't work after 3 months, then we recommended medication. Now, if somebody had only one risk factors could be a family member had a certain age or younger had a problem, being obese, smoking, and those kind of risk factors that are defined. If a person had one risk factor, the goal was to bring it below 160. If the person had two risk factors, the guideline was to bring it below 130, right? These are only the risk factors.
No, all of this amount decreases.
The more risk factor, the less LDL we want to have. Now, if patient has the disease, let's say somebody really had a heart attack, patient had a cardiovascular event, a stroke, anything that could compromise the heart health, then the recommendation was to bring it below 100. Now, if that person, for example, somebody who was 30 years old, come in with 190, it had no problem, compared to somebody who had diabetes, which is diabetic is one of those diseases that we wanted to treat because it's a risk factor for heart problem. Same person, no problem, same age, diabetes, no risk factor. This patient was okay if it was 185. This patient recommendation was to bring it below 100. If this patient also had a heart attack, the recommendation was to bring it below even 70 because it prevents further events. Did I answer your question? Very good.